Hi, everybody. Welcome. Welcome to Recent Advances in Cancer Care, New Paradigms, Novel Agents, and what it means for oncology nurses, bispecific antibodies, and antibody-drug conjugates for lymphoma and CLL. I'm Brad Kahl from Washington University in St. Louis, and I'll be moderating the program. This is our faculty today. We have Farrukh Awan from UT Southwestern. We have Robin Klebig from the Mayo Clinic, and Mollie Moran from The Ohio State University. Here are our disclosures. So the program will contain certain discussions of non-approved agents. Please refer to official prescribing information for each product for the approved indications. The educational theme of all 11 programs is to focus on the integration of new agents, regimens, and therapies into oncology practice, when and where they should be used, for whom, and how to prevent and manage associated side effects. So with that, let's kick off our program. So here's our agenda. We're just going to spend a brief minute on biology. Module 1 will talk about bispecifics in lymphoma. Module 2 will focus on Polatuzumab Vedotin. And then Module 3 will be Loncastuximab Tesirine. Module 4 will be BTK inhibitors with or without anti-CD20 antibodies. Module 5 will be combining BTK inhibitors with BCL2 inhibitors. And then we'll finish up talking about non-covalent BTK inhibitors in CLL. So, Dr. Awan, at a very basic level, how do you counsel your patients with newly diagnosed diffuse large B-cell lymphoma, their disease, and what their treatment might look like?
Thank you, Brad. Thank you all for coming. It's nice to see so many people here. When I am in San Antonio, it's hard to come to the meetings because there's so much to do outside. So it's always so much fun outside, but thank you all for being here. And I'll start off by answering this large cell lymphoma question. I think the biggest challenge for me is talking to my patient about the anxiety and the stress of their diagnosis and settling that down first. We then talk about the course of the treatment and the side effects. But the first most important thing that they need to hear is they'll be okay. The vast majority of our patients do really well, and there are some nuances based on their age, comorbid conditions, organ function. All of that is discussed after the initial shock has settled down and we have had a chance to establish a relationship with them. They trust us, they trust the team. And as long as they know that we are here to take them through this journey, which can be very varied, as you know, depends on the type of large cell lymphoma you have. We might have to tweak our treatment around, but essentially the whole idea is that no matter what happens with the chemotherapy every 3 weeks, with the scans after 3 cycles or after 6 cycles, at the end of treatment, if there's any maintenance or not, or any other CAR T or transplants, all of that comes secondary. The first thing is to establish that relationship and tell them that you're in good hands.
And I'm assuming that conversation is quite different compared to a newly diagnosed follicular lymphoma patient.
Yeah, and I think that's also important because the heterogeneity of the disease is such that the first thing I talk to them is, lymphoma is not one diagnosis. It's like 50, 60, 70 different cancers. Every cancers behave differently. So just saying that you have one lymphoma and pigeonholing you into this thing is not fair. So follicular lymphoma is a classic example. Some patients may never need treatment. And that is the biggest challenge for me, sometimes to explain it to them that you have cancer and I'm not going to treat you. And to get them over that and the rationale behind that and why am I not treating you? Should I go somewhere else? Should I get a second opinion? All of that is all tied into this whole C word, which is the cancer word. I need to get over that. I need to establish that relationship, and then everything fits. And then follicular lymphoma is a lifelong process where you may need treatment intermittently. So completely different mindsets. It's all about patient-physician relationship.
So why don't you teach us about bispecifics in lymphoma?
Sure, thank you. So we'll start off by talking about bispecifics. So before I do that, I just need a show of hands. I just want to see how many people here are comfortable with bispecifics or bites. So that, okay, fair number. But then there are some who may not have heard of it. So if you give me the liberty for 2 minutes, I'll make it very basic, very simple, and then we can go as deep as you want, because there's going to be a lot of talk about bispecifics. And there's a bunch of them. So in the next 10 seconds, I will explain the difference between antibodies, ADC, bispecifics, and obviously chemotherapy. And then we'll also touch on targeted therapy. So let's talk about chemotherapy. So I'll give you a silly analogy, all right? So nothing personal about this. Please excuse me. But basically, if you have a group of bad guys, like let's assume this room, and if you say this is the cancer room, and I want to eliminate that, what are our options? In the past, all we would do is nuke it. Destroy all of San Antonio, we will get this room. Sometimes that worked, sometimes that didn't work, and some of the bad guys in the room would survive. We're not bad guys, by the way. But that was the analogy for chemotherapy. Chemotherapy is carpet bombing. You destroy everything. But then we were like, this doesn't really make sense, doesn't really work all the times. Can we get better at it? And we developed these guided missiles that will come in from the front door, destroy a few windows, maybe a few hallways, but try to get this room as much as possible. And that is your antibody targeting the cancer, rituximab, obinutuzumab, and so on and so forth. And then we said, what if we attach a payload, a bomb, to go off when the antibody finds its target? The bomb comes in, damages a few things, maybe kill a few people, and then explodes. That's called ADCs, Loncastuximab, and so on. So that's how the field moves forward. And then we were like, how do we do better without causing all of this damage? And then we came up with bispecifics, all right? And with bispecifics, and actually right before bispecifics, the Nobel Prize happened with PD-1, PD-L1, and checkpoint inhibitors. And how does checkpoint inhibitors work? They basically activate the police guys outside in the same city to kill the bad guys. Because the bad guys were stopping the police. We were giving them the signal, don't leave us alone. And now, with the checkpoint, nivolumab, pembrolizumab, and so on, we block that signal, and then the good cops are now coming in and killing us. And then with bispecific antibodies, what we are doing is allowing the policemen who are still roaming around outside, minding their own business, ignoring the cancer guys, we tell the cops, we basically find them, and we find the cancer, this room, tag the room, and bring them together. And sometimes activate the cancer and activate the policemen to fight the cancer. That's the next step. And then there are targeted therapies and so on. The targeted therapies that we'll talk about today, the ibrutinibs, the zanubrutinibs, the acalabrutinibs, they are basically designed to get inside the room quietly, flip the switch off, turn off the oxygen. Everybody dies in the room. This is how the whole field evolves. So coming back to bispecific antibodies, they're very exciting. They're being used for different diseases, not just lymphomas. We'll quickly talk about lymphomas. There are 4 of them that are out there: glofitamab, epcoritamab, mosunetuzumab, and odronextamab is on its way. It's being developed, and all of them look very promising. And the niggles, how do you activate the T cells? How do you activate the cancer cells? How do you latch on? How aggressively do you latch on to the cancer cells? This is a slight differences in the way we make these antibodies. It's essentially an antibody backbone with some minor tweaks. Tweaks on the Y end, or tweaks on the tail end, tweaks on the FAB end, and they basically bring the cancer and the lymphoma cells together. And lymphoma cells and the T cells together. And the T cells then get activated and kill the lymphoma cells. How do you choose which one's better? You either do a head-to-head trial, or you look at the results so far. But they have made a huge difference for our patients. So we'll start off by talking about what are some of the differences. Some of them are IVs, some of them are sub-Qs, some of them are both. So if the patient says, "Doc, I don't want to get an IV," you can go for a sub-Q. If the patient wants a sub-Q That's fine. If the patient wants an IV, that's fine. Let's say the patient lives a few hours away and can only do it once every 3 weeks. Don't want to do it weekly dosing. You have an option. So there are convenience factors. That's how we can decide. And everyone has slight modified administration schedules that we can use for our patients, depending on their thing. This is just an example of mosunetuzumab. We don't want you to remember all of this, but it's nice to know the activity. In cancer, we like flat lines, not in cardiology. We like to see flat lines on our curves, which means stability, which means durability of remission. How long are our patients staying in remission? So with follicular lymphoma, mosunetuzumab looks very impressive. These were the early results, which shows that it's effective, and not just effective, it seems to be effective over an extended period of time. You're talking about 3-4 years down the road, which is very nice in patients who have failed treatment. Similarly, epcoritamab has shown similar results. Now, obviously, with different patient populations, you might get different answers, and that's why there will always be different results with epcoritamab and so on. What is also important is we found that if you have a deep remission, it will last longer. Makes perfect sense. So we need to push the bispecifics until they get you into a deep remission. Is there any one of them better than the other? You make your own mind, but basically they haven't been compared head-to-head. Some of them have a fairly high response rates, but then they may have a different type of patient population than the others. Bottom line is they're all very impressive and attractive treatment options for patients with follicular lymphoma. Moving on quickly to glofitamab, again approved for large cell lymphoma, the more aggressive lymphomas. Follicular is slightly less aggressive. Glofitamab is also very effective. Patients get into a deep remission, and the remission seems to last. And then, over time, you also see the stability of the remission. So it's not just early. A lot of those patients end up having sustained remission. So if you don't have patients who can get a stem cell transplant, or if they don't want CAR T-cell therapy or whatever, or if you just want to start off with them nowadays, that's a very, very reasonable option for our patients. You still have to talk about toxicity, and we will talk about that. Similarly, very exciting results with epcoritamab, and these have been presented. We see the same trend. We're looking at the 60 to 80-ish% responses in most of these drugs. Just depends on the type of patients you look at. And then, moving forward, can we combine things together? Can we combine other antibodies to the bispecifics to make their outcomes even better? And the answer is yes. So this is an example of mosunetuzumab with polatuzumab, very attractive. Even in patients who failed CAR T-cell therapy, it seems to be working very nicely. All right, so then we'll move on to our discussion questions.
Okay, so how do you think about sequencing bispecifics relative to other therapies for relapsed refractory large cell lymphoma?
I think when I'm looking at a patient and I'm considering bispecifics, at this point I'm also looking at the social support, their logistics, insurance coverage, all of the factors before I decide if I want to go the bispecific route or if I want to go to the CAR T route, because obviously that is also a very attractive option, but some of our patients cannot do CAR T-cell therapy, and in those patients in the relapse setting, when the cancer comes back in the second line after they failed the first line of treatment, then I'm talking to them about bispecific antibodies. I had a recent discussion with a patient, and they did not want to come in because they live 7 hours away in Texas, which again is, so they had to fly in. Obviously, doing a weekly shot was not necessarily a good option for them, but this person is okay with doing every 3-week infusion, and that's why I started this patient on glofitamab. Now, this person had relapsed after CAR T-cell therapy, so it made sense to do that. Now, we are seeing more and more good responses in patients before CAR T-cell therapy, and those patients can actually get bispecifics as a bridge to CAR T, or sometimes they can skip CAR T now. That's provocative, but maybe in the future we can just do bispecifics in patients who may or may not need a CAR T or do not want a CAR T, and then hopefully have a deep, durable remission in those patients. And we are also expecting the results in the next couple of weeks with the frontline treatment of patients with bispecifics, and we're all very excited about those results. So we'll see how this pans out over the next few weeks, actually.
And then if you're thinking about follicular lymphoma, you have Mosun, you have EPCO, and you now have EPCO R squared. So how do you choose?
So I would love to hear your thoughts, too, about EPCO R squared. But I think it's a toss-up between mosunetuzumab and epcoritamab monotherapy. One of them is IV, the other one is sub-Q. The dosing and the frequency is slightly different. But for the most part, we feel very comfortable that in our teams, we can manage these patients just fine. There are some toxicity concerns, cytokine release syndrome that we will talk about in a minute. So as long as our teams are okay with it, I see them as the same thing. Epcoritamab plus R squared, we have had a lot of experience with that. We participated in the trial, so we feel very comfortable using that regimen. And also in the frontline setting too, we had the trial open, so that has had some very durable remissions. One thing I have used it is if I have a patient, and there's always those patients, the PET scan looks like mostly follicular, but then they have a few spots that look a little different, maybe a little more aggressive. You do a biopsy, it still is follicular lymphoma, but you know that the SUV is high, LDH is high, this could be transformed. In those patients, I tend to go with EPCO R squared because I feel that maybe they may have a small component of large cell lymphoma, and I need that extra kick with the bispecific antibodies. But that's just been my recent practice. If I'm slightly uncertain, I go with EPCO R squared.
Thank you. So Robin, so these drugs have unique toxicities that everyone needs to be aware of. Why don't you walk us through what we need to think about in terms of side effects with bispecifics?
Happy to do that. Thank you. So many of us might be familiar with CRS and ICANS, and if not, I will just kind of give you a little bit of a brief reminder. So if we've done CAR T-cell therapy, we're familiar with this, and with bispecific antibodies, they can be similar or the same syndrome, but we see it a bit less with the bispecific antibodies than we do in CAR T-cell therapy. So the reminder is CRS stands for cytokine release syndrome. That's a systemic inflammatory response resulting from massive cytokine release by those activated immune cells. And I always want to point out that we want cytokine release because that's what causes the cytotoxicity, but we don't want the syndrome, or we don't want it to get out of hand. So how do you know when somebody is going into CRS? Well, it's characterized by fever, sometimes hypotension, sometimes hypoxia, and at the worst case, it can lead to organ dysfunction. This is typically managed with corticosteroids, usually dexamethasone and maybe tocilizumab and a few other things that we'll go through perhaps on the other slides. Now, ICANS stands for Immune Effector Cell Associated Neurotoxicity Syndrome. You know why we call it ICANS. It's much easier to say. So these are neurological toxicities that are associated with that immune cell activation and the cytokine release. So patients will present with confusion, delirium, aphasia, dysphagia. They're having word-finding difficulties. They might have seizures at the worst case, or encephalopathy. And this is also managed with corticosteroids, typically dexamethasone. Typically, you're also going to have neurology consultation, and they may even need levetiracetam or Keppra. Notice that we don't really use tocilizumab for treatment of ICANS because it's not effective with that. The tocilizumab is just for CRS. So I like to give you tools because I don't expect you to remember all this stuff, and I sure hope you're not taking a lot of notes because I want you to have a tool. So next week when you go back to work or next month, you'll know, where can I look this up? So I love the NCCN guidelines, and I hope you are familiar with it, or you will become familiar, because these have great resources for, you can see up in the left-hand corner, this is CRS, related to the T-cell engaging bispecific agents. I've highlighted that you can actually see where grade 1 starts off with a fever. So automatically, if somebody has a fever, they've got grade 1 CRS. And if you look over to the right under management, this will actually walk you through, what do I do? Oh my gosh, my patient has a fever. Well, it can give you a hint of, okay, should I continue treatment? Maybe I need to give some dexamethasone, and then if it's prolonged or recurrent, you may need to repeat the dexamethasone or consider tocilizumab. And then you just kind of walk down through the others. Grade 2, always these CRS grades are going to have a fever. Grade 2 may have hypotension and or hypoxia, but not to the level where they're needing pressors and they're getting by with just a little bit of supplemental oxygen. They're not quite ready for ICU, but they do need to be treated with dexamethasone, and you might be considering tocilizumab as well for these. I'm going to move on to the next slide where we can see this is where grade 3 gets a little bit more serious. The hypotension is now requiring vasopressors. The hypoxia is a little bit more serious. These patients are in ICU. You're doing supportive care with an IV bolus of fluid if needed and the vasopressors. You're giving dexamethasone and you're giving tocilizumab. On the previous slide it said consider, now you're actually giving it. And these are the patients you're probably more likely going to be resorting to the anakinra or siltuximab. And then of course grade 4, even worse. Multiple pressors may be required. The hypoxia may be requiring CPAP or BiPAP. This is when you would permanently discontinue this treatment. They will never receive it again, whereas on the other 3 grades, grade 1 through 3, you could hold treatment and then once resolved, you could go back to it. So these are scary things. You're like, oh my gosh, I hope I never see this. But we are able to manage this and walk them through it. But it's kind of nice, I think, to have an idea of when would I expect to see this. And you can see I've listed all of the different bispecifics and in what setting. So notice sometimes that these regimens, the schedule of them is different, right? So epcoritamab given subcutaneously in large B-cell lymphoma is different from follicular lymphoma. In large B-cell, you have the ramp up. I say we start them out with a little taste. On cycle 1, day 1, we give you a little pinch of the bispecific. And then on day 8, you get a little bit more. And then on day 15 for epcoritamab, that's their first full dose. So it makes sense you might expect, that one I'm probably going to see the biggest CRS risk. And sure enough. But if you look at the follicular, that schedule is different. It starts out with 0.16 on day 1, 0.8 on day 8, and then 3 milligrams on day 15. So it's day 22 that you might see the most CRS with epcoritamab with follicular. So again, just being mindful of the schedule. With glofitamab, that's even a more interesting one. You look at cycle 1, day 1, you're not even getting glofitamab. You're getting obinutuzumab because we're trying to mitigate the severity of the CRS by trying to debulk a little bit. But you can see the CRS risk is pretty substantial even on all 3 days of all 3 first doses of the glofitamab, with 56% on the first small dose, 35%, and then 29%. And then mosunetuzumab, they are mostly going to have CRS on cycle 1, day 1, very different from epcoritamab. And then you can also see it on the first full dose. So again, please do not take rapid notes on this. This will be in your slide if you ever want to look back at it. The other interesting thing, because my case is going to be about this, the mosunetuzumab has now been approved for subcutaneous use, and that is the highest time that you'll see on cycle 1, day 1, where they'll have CRS. So then turning to ICANS, or the neurotoxicity, again, they're going to present with expressive aphasia or dysphasia. They may have dysgraphia where they're not, they can't write very well. They may have a tremor. They'll have that confusion and things, maybe even seizures at the worst case scenario. Again, typically the timing is going to be during the step-up dosing, can be similar or related to either concurrent or shortly after CRS, but it could be, maybe they're not having CRS, but they're having ICANS. So you do kind of have to be on your toes with this. The defining feature for saying that somebody has ICANS is the ICE assessment tool, and I will show you that in the next slide. One thing I want to mention is that there is ICANS, and then there's also non-ICANS neurotoxicity. So maybe they're having neurological symptoms, but their ICE score is okay. So like these neurotoxicity symptoms, you might think, okay, they're having a headache. Is it ICANS? No, if that's the only thing, if it's just an isolated headache, it might be related to something else, and you can just give them, some acetaminophen or so. Likewise, if they have dizziness or a tremor, again, if it's isolated and not related to the delirium, the aphasia, those types of things. And the timing of non-ICANS neurotoxicity is variable. So I promised I would show you the ICE assessment tool. Again, going back to those NCCN guidelines, you can see the ICE assessment tool, the different things that we're looking at. You get points for each one, 4 points for being oriented, 3 points for naming things. You can see the ICE score over here, and then this is how you grade it. So this is the ICE score. If you have 7 to 9 points, you get a grade 1. But notice that if you have an ICE score of 7 and you have a seizure, that automatically puts you at a grade 3. You can see seizure, they're not having seizures on grade 1 or grade 2, so grade 3. And then if we go on to the next page, again, this will point you to how to manage it. If they have grade 1, this is what you're going to do. Give them some dexamethasone, consider levetiracetam, etc. Again, with ICANS, you don't give tocilizumab for that, mostly just the steroids. And back to you.
Okay, so Mollie, let's hear from you. So do you feel like the bispecifics can be safely delivered in a community oncology setting?
I hesitate to say yes, because there are some interventions that need to happen right away, and not just in the oncology office, but in the emergency room and all of the other supportive care areas. We even struggle in an academic center where we have protocols in place and specific guidelines and places for these folks to go if they're having a side effect, to get them through efficiently. And I worry that if that comes across in the community, that's going to be even a bigger challenge.
So most of the risk, is during the ramp up. So how about the scenario where the academic center takes the patient through the 100%. Ramp up and then hands them back?
100%. Get them started, and then once they're safe and sound, and not having any of those ICANS or neurotoxicities, then shift them out into the community, and they should be able to do fine. It would be like any other therapy that they're getting with frequent check-ins, and we only see these folks once a month as they get out in therapy, so certainly something that could be managed.
Robin, are there any long-term toxicities that we think we need to keep in mind with the bispecifics?
Definitely. I do think of it as the acute toxicities of CRS and ICANS, and then the long-term is going to be, you can have prolonged cytopenias. Infection is going to be the major thing that we have to keep in mind. And looking at lymphopenia and low CD4 counts, making sure they're on prophylactic antimicrobials, and just really being mindful of that.
Infections, yeah, for sure. Okay, so we're going to switch to our next module now. We're going to talk about Polatuzumab Vedotin, and I'll walk you through this. So people probably know that R-CHOP was the standard frontline therapy from about 2002 to about 2022. There were a lot of negative trials trying to find something better than R-CHOP, and then along came R-CHP Pola. So Pola is an antibody-drug conjugate. This cartoon shows how it works. It binds to CD79B on the cell surface. The antibody-drug conjugate is internalized. The cytotoxic payload, the vedotin, is then released. It inhibits microtubules, which then leads to cell death. And in this clinical trial called POLARIX, patients with previously untreated diffuse large B-cell lymphoma were randomized to receive standard R-CHOP chemotherapy or R-CHP Pola, where the vincristine is pulled out of the regimen and the Polatuzumab Vedotin is substituted in the regimen. Primary endpoint of this trial was progression-free survival, and the green curve at the top is Polatuzumab R-CHP, and you can see that it was a little better for progression-free survival. And how I think of this in diffuse large B-cell lymphoma, this is really the cure rate, because if it's the proportion of patients you're curing in the front line. So there wasn't a big difference here, but there was a difference. And so you appear to be curing about 6 to 7% more patients in absolute terms with our CHIP-POLA, which means they don't have to go get a transplant, they don't have to get CAR T. And if the toxicity profile is comparable, then that's a good trade-off, and we'll hear about the toxicities in the next presentation. Now, POLA is also available in the relapsed refractory setting. It's approved for use with bendamustine rituximab based upon this very small randomized phase 2 trial, but you can see that POLA added to BR improved the complete response rate considerably, and it also resulted in an overall survival benefit. So that is a regimen, POLA BR, that is available in the relapse setting. And then there are some new combinations with Polatuzumab that are just becoming available. This was a trial that was recently reported at an international meeting called POLARGO. This is for patients with relapsed refractory diffuse large B-cell lymphoma, and they were randomized to a standard regimen, R-GemOx. This is kind of an old-timey chemo regimen that's been around forever, versus that regimen with Polatuzumab Vedotin added to it. And what you see here is an improvement in the overall response rate in the POLA-containing arm, improvement in the complete response rate, big improvement in progression-free survival, and even some improvement in overall survival. So this was good evidence that POLA was adding a meaningful benefit to the R-GemOx regimen. And then right around the same time, it's sort of been I'm not going to say avalanche, too dramatic, but a mini flood of new combinations that have become available in relapsed diffuse large B-cell lymphoma. So this trial is called SUNMO, and it's, again, testing against R-GemOx. And in this case, the experimental regimen is Mosun-POLA. So we just heard about mosunetuzumab, the bispecific, and here it's combined with the antibody drug conjugate Polatuzumab Vedotin. And in this particular trial, the Mosun-POLA combo was quite a bit better than the R-GemOx for progression-free survival. So this is now another novel combination that is available for our relapsed and refractory diffuse large B-cell lymphoma patients. So just in like the last 18 months, there were 3 new regimens that were all tested against R-GemOx head-to-head. So R-GemOx, I sort of summarized the result, but all 3 trials had the exact same R-GemOx results. Complete remission rate, 25%. And really focus on the complete remission rate here in the middle column, because that's what really matters in diffuse large B-cell lymphoma. So here, POLA R-GemOx got a complete remission rate of 47%, Mosun-POLA 51%, and then a regimen that not included in my little section here because it doesn't have POLA, but glofitamab GemOx complete response rate of 58%. So we have 3 brand new regimens that we can now offer our patients with relapsed refractory diffuse large B-cell lymphoma. These are not FDA approved, but they are on the NCCN guidelines, so you do have access to these when needed. Which is the preferred regimen going forward? I don't know. They haven't been compared to one another. Just looking at the data is probably most impressive for Glofit GemOx, and so if you have a patient who's appropriate for that, I think that's a very good choice. But some patients are really frail, really unfit, and this Mosun-POLA regimen proves to be pretty non-toxic, pretty easy to give, so I can see that being an appealing choice. And then, it's always hard to give these expensive drugs in the hospital sometimes. Your hospital administrators don't like it. Starting bispecifics in the hospital can be a real challenge. We just had a patient who came in inpatient, and we were trying to figure out what to do, and the POLA R-GemOx was sort of the easiest thing to get started as an inpatient. So I can think of scenarios where any 3 of these could be appropriate for your patient with relapsed large cell lymphoma. So, discussion. So, which patients with newly diagnosed diffuse large B-cell lymphoma are you prioritizing the use of POLA R-CHIP? Farrukh, I'll ask you, do you give all of your high IPI scores Polar CHIP, or do you make some other determinations about who gets this regimen versus standard R-CHOP?
I understand the issue with Pola R-CHP, and there are some subsets that might benefit a little bit more than others. But in our practice, we have transitioned to Pola R-CHP for all patients unless there's an insurance issue.
And if you have a patient in the relapse setting, I just went through this laundry list of new regimens. Do you have an emerging favorite of these new options that are available to you?
Yeah, so I completely agree with what you suggested. So if we have a patient who have relapsed a few months after receiving their initial R-CHOP therapy without Polatuzumab, we are leaning more towards Polargo or Polatuzumab with R-GemOx. That's become our standard chemotherapy. But if somebody is chemo-refractory, primary refractory, R-CHOP didn't even touch them, they're frail, they have multiple other comorbid conditions, we have also started using more and more Mosunetuzumab with Polatuzumab. So a non-chemo arm for our frailer patients and primary refractory patients, and for our less frail, later patients, it's Polargo.
Okay. So let's move ahead. Mollie, do you want to talk to us about tolerability considerations with Pola? And I think you have a case, too, that we want to hear about.
I have to stand up because I can't see over to see what's
in fact, they want us to go right to your case.
I can't see what's going on over there. So we'll talk about a case study with Polatuzumab Vedotin. 65-year-old farmer, male, noticed a mass in his right lower neck that continued to increase in size. He goes to his primary care doctor. They finally get him to a biopsy. He has a diagnosis of diffuse large B-cell lymphoma. ENT actually and eventually does the biopsy. He comes to us. He's got high-risk disease. He's got a high Ki-67. Ki-67 is a marker of proliferation, and so when your Ki-67 is elevated, it's a rapidly dividing tumor, and so we use that as a sort of a risk. He's stage 4, germinal center, diffuse large B-cell with an IPI of 2, IPI, International Prognostic Index, and an IPI-2 isn't all the worst, but it's certainly not nothing. He gets a PET scan. He has a big lymph node in his belly. Max SUV is 15 plus. He has well-controlled diabetes and hypertension. The discussion starts with what's standard of care versus non-standard of care. For the longest time, it was R-CHOP, as we keep saying, R-CHOP. And then our Pola chip was recently approved by the FDA as the new front runner. And so that takes away the vincristine, the Oncovin. And so it turns out that this is better progression-free survival and overall survival. And so this is what the decision is for him to move forward. And he goes on and he gets 6 cycles of therapy. Pre-treatment, he started on prophylaxis for PJP and an antiviral. Patients who are receiving treatments for lymphoma often are at risk for developing some of these pneumonias, the PJP that's seen in patients who are immunocompromised, certainly recurrence of reactivation of shingles and herpes viruses. He gets growth factor support with each cycle. We're trying to keep him from having neutropenia. That's another high risk that happens when patients are on combination chemotherapy. Remember all of the data from back in the day that if you keep people on therapy, on schedule, on track, they're going to do better, so they may require growth factor support. These are all nursing led initiatives where you have to do the teaching, you have to make sure they can get the medicine, can they afford it, can they get it, can it get shipped to them. No Neupogen is going to keep you from neutropenia, or no growth factor is going to keep you from neutropenia if you don't have it, or if you're not taking it. It just doesn't work that way. He gets alopecia, constipation, kind of common side effects that we see with many of these lymphoma treatments. He can use over-the-counter medicines for constipation. I always tell my patients, if you haven't gone in 2 days, you got to start ramping up the over-the-counter stuff. Cycle 3, he comes in, he has numbness and tingling in his feet and hands. He's having difficulty buttoning his shirt. He has to cut back on his duties on the farm. The dose of Polatuzumab, Vedotin, is reduced because the neurotoxicity or the neuropathy can be pretty present in these drugs, and it's not always reversible. So you don't want to let this ride too far. I had a patient come in once walking like he had on ski boots, like Frankenstein, and I was like, "How you doing?" He's like, "Great." Great. You got a little toxicity? What do you mean? So you have to be assessing these things all the time. He gets COVID. He gets treated with anti-COVID medicine, antivirals. He gets a PET scan, and after number 4, good response. Neuropathy is improving with the lower dose, and he ends up completing 6 cycles. PET scan has a day vol of 2, and complete metabolic response. He has noted rib fracture, likely to a cow incident.
What would that be?
The farmer.
No judgment. No judgment. Let's see what the slide here is.
We'll stay here. So the dreaded cow incident. Side effects of polarobin neuropathy is a big one. Do you warn people ahead of time about that one, and any others that stick out in your mind?
I would say that's really the main thing. Just like with the rest of the R-CHP regimen, the cytopenias. So we definitely give growth factors prophylactically. We don't wait to see if they're going to get it. But yeah, I would say that's the main thing. And in our experience, I feel like it's not even quite as bad. I don't know about you. Do you see as much of it as you did with the vincristine and R-CHOP?
Not nearly as frequent,
It's better,
but certainly the same intensity.
Mm-hmm. Mm-hmm. Yep.
And it can be a very long-lasting toxicity that patients bring up visit after visit after visit.
Yes.
So anything you can do so dose reductions are probably
catch it
appropriate
early.
if it starts to become a problem.
Yeah.
Mm-hmm.
Yeah. Okay. All right. Thank you both. We're going to move on to our next session. We're going to talk for a minute about Lonca-T. Lonca is another antibody drug conjugate similar to Polatuzumab. It binds to CD19, which is pretty ubiquitous on B cells. The cytotoxic payload here is this thing called a pyrrolobenzodiazepine dimer, or PBD dimer. It actually is a DNA damaging agent like chemo. This is so potent, however, you can't give it as a free drug, so you have to give it attached to a monoclonal antibody to try to get the vast majority of it inside the tumor cells to leave healthy cells alone. This drug received its FDA approval based off this LOTUS-2 study. This was a single-arm phase 2 study for patients with relapsed diffuse large B-cell lymphoma, 145 patients. The Lonca is dosed intravenously over 30 minutes, and it's given every 3 weeks, so it's kind of a patient-friendly schedule. It's just one trip every 3 weeks, 30-minute infusion, not bad. The dosing is a little quirky that you get a bigger dose for cycle 1 and 2, 150 micrograms per kilogram, and then it drops to 75 micrograms per kilogram for subsequent infusions. And in the trial, you could just keep giving it indefinitely, but we have since learned that this is not a drug you want to keep giving indefinitely. There are definitely cumulative toxicities, which we can talk about. So I think this is a drug you treat to best response and then get out of Dodge. So here are the results from the study. The overall response rate was 48%, not bad. Complete remission rate, 25%, not bad. You can see for the patients who did achieve a complete remission, they can be durable. This is the progression-free survival curve for the entire group, and so you can see there's a lot of non-responders or short remissions, but there are a subset of patients who get long-term benefit from this agent. So it's now FDA approved for patients with relapsed diffuse large B-cell lymphoma who have failed at least 2 prior lines of therapy. So this drug needs a confirmatory trial because it just has an accelerated approval right now. So there's a couple of ongoing trials. There's this trial called LOTUS-5. This is a phase 3 trial where Lonca is combined with rituximab and compared against immunochemotherapy in relapsed large cell. And then they're also studying the drug Lonca-T in combination with the bispecific antibody glofitamab. So we have some results from the LOTUS-5 safety run-in. So this is just 20 patients getting the Lonca rituximab combination. Overall response rate 80%. Combo looks pretty good, better than single agent Lonca-T, and certainly gave people confidence in moving into the randomized clinical trial, which is still enrolling, and we don't have any results yet. And then this is the early data from the Glofit-Lonca combination studies. You can see 15 patients treated with this dose of Lonca, 120 micrograms per kilogram, 15 patients with this dose of 150. And no matter which dose was given, the complete response rate is incredibly high, over 85%. So this looks like a really interesting, hopefully very active combination, and we're waiting for the mature results from this study to tell us if this is yet another sort of novel combination that we can offer our patients. And then the drug has actually been studied a bit now in follicular lymphoma. This was a trial done at the University of Miami and a few other sites in relapsed follicular lymphoma. So Lonca plus rituximab. And look, if you get this combination, you will almost never die. That's how active it is. But it is a very high response rate. It does not have an FDA approval yet, but has just been listed in the NCCN guidelines as an option for third line and beyond. So this rituximab Lonca-T option is now something you could offer a patient with relapsed refractory follicular lymphoma based upon NCCN guidelines. It does appear to be a very active combination. So I have a patient case that I'll try to walk you through quickly. This was a woman who was diagnosed when she was 70 in 2012 with diffuse large B-cell lymphoma, and she was treated with R-CHOP chemotherapy. She went into remission, and that lasted for 6 years when she was found to have relapse with a new retroperitoneal mass, and it was rebiopsied, and it showed recurrent large cell lymphoma. She's now age 76, and she received R-GemOx as salvage for 8 cycles. She was in a PR after 4 cycles, but was progressing after cycle 8. And so at that point, she was referred in to see us. This is in 2018. And I recommended that we try Axi-cel on a clinical trial that we had for her. I thought she was fit enough to do that. She did not need any bridging. And she achieved a complete remission on her day 30 PET, and she was doing great for almost a year. But then she relapsed after CAR-T with a new mesenteric mass, just found on surveillance imaging. We rebiopsied it was large cell lymphoma. We had Lonca-T on a clinical trial at that point, and we offered that to her. She received 8 cycles. She achieved a complete remission, but she started getting the third spacing, which you can get with Lonca, where people start to get edema. I remember coming into clinic, and her face was really round and puffy, and her eyes were little slits because her eyelids were so puffy, and I was thinking, okay. And we didn't know a lot about the drug at this point, so I felt like I probably overtreated her by a couple of cycles, and now we were in a little bit of a pickle. It's hard to get the fluid off of these patients. The Lasix doesn't work very well. Spironolactone works better, but it took a few months to get her looking back to her old self. Anyway, she had a nice remission that lasted about a year, and then she had another recurrence, and this is in February of 21. So then she received glofitamab on a clinical trial. It was not yet FDA approved, and she had a great response. Here's her pre- and post-Lonca images showing the pre-scan and the remission scan. So she is now 5 years out from the glofitamab and still in remission, which is amazing. She's 82. There were some long-term infectious complications that we had to deal with, and some cytopenias, but she's doing really quite well at this point over all these issues. Her and her daughter, they live like near the Iowa-Missouri border, so it's like a 3 to 4 hour drive to come here. I see her like every 6 months now, and I'm like, gosh, you have to come so far. And they said, no, the food here is really good. St. Louis is pretty good for food, so they actually like the trips. They want to keep coming every 6 months, which is okay with me. Okay, so discussion questions. Robin, Mollie, do you have any experience at your site with Lonca? Just curious if you've experienced with this drug and what you've seen.
I would say, from our experience, when you get to that point where they've relapsed, maybe post-CAR T or bispecific, or you're looking at these way down the road regimens, and in Rochester at Mayo Clinic, we have a lot of people as well who come, several hours, and the schedule, I would say, is very favorable, giving it, it's 1 day every 3 weeks, so that's definitely favorable.
Yeah. Any experience at your site with Lonca?
I have very little experience with it.
Okay. Well, let's move on to Robin's presentation, because Lonca is a drug where I feel like there's a bit of a learning curve, so we should spend a few minutes talking about that.
Okay, thank you. So this slide just really goes over what I just said, what the schedule is. It's given IV every 3 weeks. Cycles 1 and 2 are 0.15 milligrams per kg every 3 weeks, and then cycle 3 and beyond, the dose actually drops in half. But the important thing is in the bottom of this slide, pre-medicating them with dexamethasone, 4 milligrams PO or IV twice a day, starting the day before. And that's really important to remember because, you have somebody coming in on Monday for treatment. They better remember on Sunday to start their medication. We had an issue with that with one of the patients, and they forgot to take it. And I panicked because it was this man who drove from Iowa north several hours and had to rely on a driver who was a little cranky. And we panicked and we said, oh, it's okay, as long as we give the dexamethasone 2 hours before. So it saved the day. So this talks a little bit about the LOTUS study. I'm going to move on. We talk about cytopenias quite a bit, the elevated GGT, but more importantly, some of the side effects that are different because of the pyrrolobenzodiazepine dimer. Did I say that well?
Yeah.
I just learned to say that today.
Yeah.
So with these new drugs, we have new side effects. And so here's one that we don't see a lot, the edema and the effusions that you described. Because of this disrupts the vascular endothelial, it just causes some injury, and so you have leakage, and so you can have this edema and these effusions. So edema, whether it's peripheral, facial, generalized ascites, pleural effusions, pericardial effusions, and that the worst case scenario, you can see cardiac tamponade. Not very often, but definitely makes you want to say, I think I'm going to make sure that this patient gets this treatment, this dexamethasone, to make sure it doesn't happen. And so monitoring for those things, watching to see, are they having shortness of breath? Are they having weight gain? Are they having chest pain? And making sure that, somebody is aware to order imaging, chest x-ray, CT chest, echocardiogram, and those types of things. Because if they have this, of course, you're going to want to hold the drug until it resolves. And then diuretic, as you mentioned, spironolactone is typically used. And then cutaneous reactions, again, a little bit different. Sometimes we can see rash with certain things, but these rashes and actually the photosensitivity reaction is a little bit more pronounced. I think we're used to seeing and being careful with that with doxorubicin, but definitely is something here that we want to make sure that they are not getting exposure to direct sunlight, even through glass windows. They have to be careful. Make sure they're wearing sun protective clothing, using sunscreen, avoid tanning beds. I hope none of our patients are going to tanning beds. But
can I tell you a rash story?
Yes, please.
The public service announcement. I always tell people about all the stupid things I do. So I had a very elderly patient seeing us at one of our satellite sites, relapsed large cell, probably about 90 years old, and he was there with his son. They really wanted to do another line of therapy, but he had to get back and forth from the assisted living place. He's wheelchair bound at this point, maybe mild dementia, pretty good mentally, but just a little off. Anyway, I'm trying to think, okay, what are we going to give him? And I decided on Lonca just because I thought it would be easy with the travel and the back and forth. And then I told him and his son about, the photosensitivity and not to get too much sun. But we didn't call the facility, and bless their heart, but they just sat him outside in the sun all day, and because they didn't know, right?
Right.
So when I saw him back for, I think it was cycle 2, he was just a blistery mess. It was so horrible. So the photosensitivity is real. Keep him out of the sun.
That was great. Wow. Thank you. So topical corticosteroids, he might have needed a bit more than that, but otherwise some symptomatic relief. So there can be other, we're used to looking at lab abnormalities with the cytopenias, using GCSF if their neutrophil count drops. Of course, they can get febrile neutropenia and infections. Thrombocytopenia, you're going to hold it if their platelet count isn't 50,000 or better. Anemia, hepatotoxicity, so an elevated GGT. And I don't know about you all, we don't routinely check GGT, but when we give Lonca, we do. And the interesting thing with this is, the first patient that I ever treated with this, yes, the GGT was elevated and we got all excited. And then you look at it and it's like, oh, it has to be grade 3 before you hold it. And look at grade 3 has to be 5 to 20 times the upper limit of normal. So I think normal goes up to maybe 60, and I had somebody who was at 150. Well, it wasn't 300, so we're like, yeah, we can keep going. And it's usually reversible with dose delays, so it does not tend to cause significant problems, or from our experience anyway. Let's see. I can go into my case presentation?
Yes.
All right. Let's see. So this is a 43-year-old male correctional officer. He's married, has a teen daughter, lives about 2 hours from Rochester. He presented with a testicular mass. He had a left orchiectomy. It's turned out to be large B-cell lymphoma. Because of this, you might know that they're at risk for CNS involvement. So at baseline, we do CSF analysis and MRI of the brain. Those were negative. His bone marrow was negative at baseline. He was treated on a clinical trial that we had at the time with parsaclisib and R-CHOP, had 6 cycles, went into a CR, had radiation to the scrotum, which is typical for treatment of testicular lymphoma. And then he had prophylactic high-dose methotrexate for 3 cycles. Again, that's what our standard is at Mayo Clinic. So 8 months later, though, he self-palpated a left inguinal node. You can see where it is there on the scan. That was biopsied and showed large B-cell lymphoma. So that was an early relapse. He relapsed within a year. So he went on to CAR T-cell therapy with axicabtagene ciloleucel, went into a CR. But then 7 months later, he noted these nodules on his lower extremities, and they were biopsied. They were diffuse large B-cell lymphoma. There wasn't very much of them. There weren't very many of them. So it was treated with radiation. They kept popping up, so then he had radiation to his bilateral lower extremities. I think we could have another discussion about whether tattoos are important in the development of lymphoma.
Did you draw that tattoo on his foot, or was that there?
Did what?
That tattoo on his foot looks like it was drawn post.
Right. So 2 months later, so he finished his radiation. 2 months later, he had a systemic relapse, you can see on the PET scan. So biopsy-proven relapse. So now we're up to treatment number 4. And at that time, he was given salvage rice, rituximab, ifosfamide, carboplatinum, and etoposide. Had 3 cycles, so he had a decent response so that he was able to go to autologous stem cell transplant. But unfortunately, that's his day 100 PET scan. That doesn't look so good, does it? Biopsy-proven cutaneous and bone marrow now involving 60% of his bone marrow. So he was seeing some cytopenias already. At that point, then we gave him Glofeed Gemox. And unfortunately, get a picture in your mind of this PET scan and look on the left. Worse, right? Didn't respond. So at that time, we're up to treatment number 6, and he was given Loncastuximab. He actually tolerated it well. He didn't have any trouble with effusions or edema or skin. He had a lot of cytopenias because of his bone marrow involvement, and so was getting transfusions. But otherwise, he tolerated the Lonca well. He had some kind of a mixed response. Now at this point, I'm going to see him on Monday for a second cycle of something called Viper, which is not part of our talk today.
Okay, thank you. So let's move on to Module 4, and now we're going to talk about the role of BTK inhibitors alone or with anti-CD20 antibodies for newly diagnosed CLL. Farrukh, on a very basic level, when you have patients with newly diagnosed CLL who need treatment, what are the factors that you integrate. We have all these really good options now. So what are the factors you use to help decide what type of approach you're going to take for a given patient?
So I think as the field has evolved, we have moved on from the staging criteria, although I just had a patient the other day, she was fixated on knowing the stage. And I had to counsel them that staging is important, but it's the CLL-IPI score. Like Mollie said, for lymphomas it's the same, for CLL it's the CLL-IPI score. And if you look at the CLL-IPI score, which determines the aggressiveness of the disease, it's primarily driven by two things. It's the del17p TP53 mutation and also the IGHV mutation. So if based on those are my first branch points. If you're unmutated IGHV or mutated TP53 or del17p, I'm thinking one way. For all other people, I'm thinking another way. Simple at this point, fortunately. It used to be more complicated, more nuanced. I think it has gotten more and more simple. And that kind of goes into the next point of the discussion is, obviously, then you look at the age, the cardiac comorbid conditions, the hypertension issues, atrial fibrillation, kidney function, logistics, cost, copays, all of that factor into it. But if I'm solely talking about the disease in my mind, IGHV, TP53 mutation, and one important piece of information, despite the fact that we know that these are the two most important risk factors for CLL, how many patients in the US get tested for it? Less than 50% or around 50%, which is a shame. It's like saying that you have breast cancer and you don't test for ERPR. So I'll just rest my case.
Okay. Let's go into your presentation.
So that's the thing. I mean, we have to really understand the disease biology so we can order the right test and move on. But the discussion shifts. Now we were talking about hitting it hard, Glofi, Gemox, Viper, Loncastuximab. The goal is to cure. But sometimes we don't need to do that. Do I need to treat the cancer? And the answer is we don't need it all the time. Sometimes yes, sometimes no. And how do we decide? So let's talk about it. So before we talk about it, when we were growing up, when Mollie and I were young, we would do chemotherapy. And she's probably done more chemotherapy than most people in the room. That was the standard, FR was what we were famous for, and that's what we gave to everybody. And then, pentostatin and all of that. But now I feel that it's easy for me to say, and I hope you agree with me, that chemotherapy has no role for CLL, so we can move on. If somebody is still getting chemotherapy, you really should question about why. And maybe there's a nuance that they are using it to treat patients with a chemotherapy, but really, there is no role for chemotherapy. Again, talking about the patients in the US right now, it's still around 10 to 15% of patients still getting chemotherapy, despite the fact that we have access to some of the best treatment anywhere in the world for our patients with CLL. So moving on to when do you treat? This is where the art of medicine comes in. If you feel lousy, if you're having night sweats, and if you're symptomatic from your disease, and for some person, it could be, I had a patient the other day, high-functioning executive. Their issue was, I'm only running 8 miles and not 10 miles. And I was like, 2. And she was so distraught because that's fatigue. And she's like, I've always been able to do that, So everyone is different. Some people have maybe a different definition of fatigue. So fatigue is always tricky to determine. So you have to talk to the patient, figure out how the disease is causing you to have issues. And then you decide if you have a big lymph node, if it's in the armpit. And I crack a joke about this. I have this big guy, 6'5", 300 pounds. He has a big mass in his belly. That's his SLL-ish, CLL-ish picture. He doesn't have a lot of blood disease. It's mostly lymph node disease. And I've always told him, I'm not going to treat you until you're symptomatic. But his mass keeps getting bigger and bigger, and now I can feel it, even though he's a big guy. And the last time I felt it, it was pretty big. It was almost like he's 8-9 months pregnant. And I did a CT scan, and it was like 23 centimeters. And I was like, dude, we need to fix this. And he's like, no, doc, that's my beer belly. And so he won't let me treat him. And he's asymptomatic because he trusts us that he's been following with me for 7 years now. So he's like, I'm just going to keep an eye on it. And he shows up every 3, 4, 6 months whenever I want him to show up, and he's cool with that. The other hand, if there's a lump right there and he can't breathe, 2 centimeters is enough. Happened the other day. Happened a subcarinal lump was literally this big. Rest of the disease was so-so. The patient could not stop coughing. Constant cough, day, night. I couldn't talk to the patient because he was constantly coughing, tried steroids, tried everything, didn't work. So that's the patient you might treat. So the point of all of this is where clinical judgment comes in. You can follow the NCCN criteria, you can follow the IWCLL criteria, whatever you want to follow, that's fine. Anemia, thrombocytopenia, night sweats, spleen enlargement, painful splenomegaly. It's basically talking to the patient. Treat the patients. Try not necessarily only to treat the numbers. And if you are treating the number, the most useless number is white count. Don't treat the white count. There is no magic cutoff for a white count. High white count doesn't necessarily mean CLL patients needs treatment. This is not acute leukemia. That's a different story. So white count is only good for one thing, and that is anxiety. And so please don't let it cause a heart attack and in a roundabout way cause problems. So don't treat the white count, treat the patient. All right? So and that's why I say elevated leukocyte count is not a reason to treat. Hypogammaglobulinemia, paraproteinemias, those are common in patients with CLL. We don't treat those patients. All right, so let's move on to how we got to the post-chemo era. We started off with acalabrutinib, obinutuzumab, and acalabrutinib alone. This study was very important. Why? We had the BTK inhibitors. These are drugs that go in, flip the switch off, the cancer cells die. We have acalabrutinib. Ibrutinib was the first one, zanubrutinib, and now pirtobrutinib. So there's multiple options. Acalabrutinib was very effective, so can we combine acalabrutinib with a CD20 antibody to improve the effectiveness? And the answer is yes, we can. This study was not designed to look at this difference, but the difference is pretty provocative. You're looking at more than a 10-12% difference in progression-free survival, adds a couple of years to remission. That's very provocative. So that's why we started adding it in some patients who would be able to handle this. Similarly, toxicity-wise, it does increase the risk of infections, but for the most part, if you handle infections, 6 months of obinutuzumab with acalabrutinib does lead to a better disease control in not all patients, but most patients. All right. Phase 3 study, Sequoia study, was with zanubrutinib. Zanubrutinib is another really good option that again compared zanubrutinib to bendamustine and rituximab, chemotherapy, another nail in the coffin for chemotherapy, and no surprise, zanubrutinib was very effective as compared to bendamustine, rituximab, and multiple such studies with all of the BTK inhibitors have been done to show that BTK inhibitors are better than chemotherapy, and potentially adding the CD20 can make it even better. There are issues. Headaches can be a problem with acalabrutinib. Hypertension, bruising can be an issue with zanubrutinib. Bleeding is an issue with all BTK inhibitors. Atrial fibrillation, some are high, some are low. The point is, if we know about these things, we can manage our patients better. All right, so phase 3, the Gaia study, the CLL13 trial. Why is this important? We're now combining various things with various things, doublets versus triplets. What's the take-home message? The message is, can I combine all of my effective drugs up front? And more importantly, which CD20 antibody am I going to use? Am I going to use rituximab or obinutuzumab? And turns out that in this particular trial, obinutuzumab was better than rituximab. This is the reason why for CLL patients across the board, we use obinutuzumab, even in the frontline setting and the relapse setting, and that has become the standard CD20 antibody rather than rituximab. So for us, obinutuzumab is the way to go, and if I'm thinking about disease with my high-risk or low-risk patients, that's the branch point that I'm thinking. For my unmutated, TP53 mutated patients, I will use acalabrutinib with or without obinutuzumab. That's up to you. Or I use zanubrutinib plus venetoclax. That's a completely different discussion. And then for all my other patients, I have multiple options now for our patients. So they do really well. Happy to talk about it more.
So let's do discussion. So when you have a treatment-naive CLL patient, who's the most likely one you're going to recommend continuous BTK versus time limited? Obviously P53, but what about the IGHV unmutated?
So we didn't talk about it, but the Amplify data with acalabrutinib with venetoclax, and also I included the zanubrutinib plus venetoclax on my slide. So I have started switching mostly to time-limited therapy. I feel that most of us would want to stop treatment after a certain time frame. So that's why I've switched pretty much exclusively to A plus V or Z plus V. So those are my combos. Now, whether 12 months is enough, that's another completely different debate. We can talk about it all night. But what I'm also talking to my high-risk TP53 mutated patients is potentially continuing on therapy perpetually. Now, is that the right approach? We need more evidence to stop treatment. But I'm doing doublets, oral doublets, maybe in some patients adding a triplet, which does increase the risk of infections.
Right. So when would you add the anti-CD20? What's the scenario?
The young patient in which I want a deeper remission, because if you look at the depth of remission with the triplet, it was much higher with the triplet arm. Most of the results that showed that triplet therapy with the addition of CD20 antibody caused increased infections. It was mostly COVID infections, mostly from countries that did not have access to COVID care in that trial that was just reported. That's why it tweaked the mortality benefit towards against the triplet therapy. But in my mind, triple therapy gets me into a deeper remission if I can safely get the patient through the therapy without infectious issues. The deeper the remission, the longer the remission lasts, and the better the outcome. So for my young, healthy, fit patients, I want to go all in with triplet.
Okay. So let's hear from Mollie about some of the practical considerations and how you deal with comorbidities when you're using first-line CLL therapy.
Absolutely. So we'll do a quick case study. 72-year-old gentleman, retired police officer, CLL for 4 years, has an increased lymphocytosis, now has thrombocytopenia and increasing lymph nodes. Dr. Awan touched on this when you said who needs treatment. When you take all comers, about a third of the people with CLL never require treatment. And so that's why we don't start treatment right when you're diagnosed, because a lot of people want to say, you told me I have leukemia and now you're telling me you'll see me in 6 months. That doesn't seem realistic, but it's because a third of those patients are never going to need therapy. He has deletion 11q, he's IVGH unmutated, and he has a relatively high beta-2 microglobulin. So he's considered a high-risk disease with the unmutated. He has well-controlled diabetes and hypertension. The kicker is he's a caregiver for his wife who has early dementia, and they live a bit of a distance from the clinic. So it's time to start considering therapy. Confusing slide. Lots of numbers, lots of letters, lots of things. And as we said, there's either single therapy, single agent therapy, 2 agents together, 3 agents together, time limited versus continuous therapy. There are some caveats to using some of the therapies, although time limited is the way we like patients to go, and patients like to go that way. It is a heavy front-end loaded therapy. You're in the clinic 2 days in a row for sometimes 5 weeks in a row. At minimum, you're there at least 1 day a week for 5 weeks in a row. If you have a lot of bulky disease, we might have to put you in the hospital to do it. It's a therapy that in the front line you can stop after a year, but in the second line you have to stop. You can go after 2 years. But again, the patient has to fit the therapy has to fit the patient. And this gentleman is not willing to give up those hours away from home with frequent office visits because he has a wife with early stages of dementia, and he has to be there to keep her safe. So when you look at the NCCN guidelines, there's BTK inhibitor by itself, BTK inhibitor with a monoclonal antibody, venetoclax, which is a BCL2 inhibitor, either in combination with other medicines like ibrutinib or acalabrutinib or another monoclonal antibody. And so it changes, and the risk factor of deletion 17p, which is a piece of chromosome missing in the chromosomes within the CLL cells. Not all the chromosomes of all the cells, but within the CLL cells, there's a piece missing off chromosome 17, and those patients tend to have a more aggressive type of CLL. They tend to not respond to single agents, and they tend to need treatment sooner than later. So it does make a difference when you look at cytogenetics and FISH in CLL. BTK inhibitors are Bruton's tyrosine kinase. It's a protein in the CLL cells. When it's upregulated, it tells the cells to stay alive. By blocking that protein, you tell those cells go off and die like they're supposed to, like normal cells would. There are shared toxicities that are common amongst all of the BTK inhibitors that are things like high blood pressure, risk of bleeding, increased bruising, atrial fibrillation, and then there's a risk of cytopenias and GI side effects. A lot of times the GI side effects are self-limiting, so a couple weeks and they go away. Same thing repeated, different form, different colors, lined up better, easier to see. Oh, they also get weird nail and hair changes. Their fingernails split and their hair gets curly in the back, and there's not much you can do for it. You can try things like biotin, but you have to keep in mind that biotin, when you're testing thyroid, it may interfere with your thyroid function tests. BCL2 inhibitors, on the other hand, block a protein called BCL, B-cell lymphocyte 2. It's like stepping on the gas pedal. If you keep proliferating, and if you block BCL2, it blocks that from happening, so stop proliferating. It's another oral agent. When you look at it in combination with other medicines, it's when you give doublets or triplets, you're always worried about adding more side effects on top of side effects on top of side effects when you combine things. However, in these oral inhibitors, that doesn't happen. There are side effects for BCL2s, there's side effects for BTKs, and they don't make them worse by adding them together. The concern with using something like venetoclax or a BCL2 inhibitor is that you have to do a stepped-up dosing because there's a high risk of tumor lysis syndrome. It works so well, it busts up all the cells all at the same time, and so we've been able to mitigate those problems by doing it in a smaller dose over a longer period of time, and monitoring very closely for what we call tumor lysis syndrome, rise in potassium, phosphorus, calcium, kidney function, lots of hydration, allopurinol, resburicase if you need it. They're monitored very closely. And again, it takes a couple of visits a week to get escalated up on these drugs, something this gentleman did not have for us to spare. So he goes on acalabrutinib, and after the first month, his white count jumps up to 159,000, but most of them are lymphocytes. And this is a common toxicity when you start on a BTK inhibitor. The ALC goes up, and you can see that number double up in short order. Over the course of about 6 to 8 weeks, it'll start to come down into the normal range. As that one's coming down, the platelets will come up, the red blood cells will come up, kind of clean out the garden to get the good stuff to grow, so you're making room in there. And so as you get the white stuff out, the good stuff can grow back up. A lot of times patients will complain of achy joints. We call it palindromic rheumatoid arthritis. This joint, that joint, every other joint, never in the same place, happens in the morning, happens in the evening. Tylenol is a good way to approach it. If it needs to be more than that, sometimes we do a little bit of a steroid taper. There's a risk of bleeding when you're on BTK inhibitors, so you have to hold the BTK inhibitor for major procedures and minor procedures a few days before, day of, couple days after, depending on how major the procedure is. There's also a risk of hypertension. He gets high blood pressure. We often send them back to their primary care doctor to manage their high blood pressure. We also try to get a baseline EKG because there is a risk of arrhythmias, and we want to make sure that they don't have anything brewing underneath that we didn't. There may have been there that may not have been caused by the BTK inhibitor. We also are fortunate to work with onco-oncology. Every 3 weeks he gets weekly labs for the start of therapy and monthly visits for the first 3 months, then 3 months after that for 2 years, and then every 6 months. So it's a spaced out regimen. It's very well tolerated. 95% of the people who take BTK inhibitors have a good response. When you get out to 5 years, 3/4 of them are still taking the same drug with the same good responses. So he's 12 months. We make him see his dermatologist annually. Increased incidence of basal cells and squamous cells by about 10 to 12%. He gets his colonoscopies on schedule. Again, like I said, he sees his primary care doctor for high blood pressure and diabetes mellitus. We recommend no live vaccines and an annual flu shot. And believe me, in Ohio, sometimes that is a discussion you don't want to have.
What are the most important comorbidities in your mind, Mollie, when you're choosing therapy?
Cardiac, we always want to make sure that they're not having already coming into it with an uncontrolled AFib, because that would, BTK inhibitor may not be the best frontline approach to that. There's a lot of CYP3/4 inhibitor interactions with BCL2 inhibitors, so you have to make sure what kind of concomitant medications they're on. Well-controlled hypertension. If they're already on 3 antihypertensives, maybe not a BTK inhibitor. So those are the big ones.
Great. So let's talk a little bit more about tolerability of the different covalent BTK inhibitors, and let's hear from Robin.
Okay, thank you. All right, so this is kind of a busy slide, and I will tell you, I was driving myself crazy trying to figure out what the percentages of all these were, because you look at one study and it'll say one thing, and then I've got to change my slide. So just know, yes, cardiac toxicities are a possibility. And you'll notice that ibrutinib, it seems to have the higher numbers, which I think is one reason that we are not favoring it as much and instead turning more toward acalabrutinib and zanubrutinib. But as Mollie alluded to, atrial fibrillation and flutter, rarer likelihood of ventricular arrhythmias, hypertension, we mentioned, bleeding. And so as Mollie mentioned, hold the drug of 3 to 7 days and be aware of what the minimal bleeding is. For like a colonoscopy or endoscopy, you'll hold it for 3 days before and after. For Mohs, and of course these patients are having Mohs because they have a higher likelihood of having skin cancer, 3 to 5 days, and for major surgery, 7 days. One thing to keep in mind is that if you're holding the BTK inhibitor in a CLL patient, there is this phenomena where they could actually have a flare of their disease while they're holding it. So if they're holding, 7 days before and 7 days after, they're off their treatment for like 2 weeks. So they can actually have a flare, and it's going to look like they're relapsing, but actually they're not. We actually have seen patients in our clinic who were referred from other institutions that, they're progressing, but it's like, no, actually you just were on hold, so start your medication back up, and most frequently it'll get back under control. And again, the stroke risk is minimal, but there. So monitoring, just as you said, doing a baseline EKG. We're monitoring, obviously, blood pressure at every visit. We're clinically monitoring for atrial fibrillation when we do our physical exams. We also work closely with cardio-oncology. And it's good to know that atrial fibrillation is not necessarily a contraindication to BTKI, but just has to be monitored very closely, especially if they do need to be on like a direct oral anticoagulant. There may need to be some dose adjustment of one or both of the medications. So a long list of other potential side effects like fatigue, that's multifactorial. Sometimes the disease at baseline is causing some fatigue. Headaches, definitely with acalabrutinib. Probably many of you, if you've ever worked with acalabrutinib, you're aware of this. But the nice thing is it typically resolves within a month, very amenable to increasing caffeine, making sure they're well hydrated, using acetaminophen, again, avoiding NSAIDs because of the increased bleeding and bruising risk. Diarrhea is something that can happen using loperamide, and when you have a medication such as ibrutinib where it's a daily dose, moving that to the evening can sometimes help. Arthralgias and myalgias that we can see with a lot of things, supportive care using acetaminophen, stretching, yoga, remaining active. You can see using topicals, whether it's heat, topical menthol, diclofenac, and then talking about the rash, again, using topical corticosteroids if needed. Petechiae and bruising, that's just a thing. I often tell my patients, well, I guess you're not going to be able to be a model for your arms anymore, because some of them, they can have some pretty purpuric lesions. But they're not really hemorrhaging. It's just more almost cosmetic. The nail splitting we talked about, cytopenias, of course, neutropenia, and then infections, the big one. I probably should have put this in bold, but making sure vaccinations are up to date, the prophylaxis with acyclovir for HZV and HSV, consider PJP prophylaxis with either trimethoprim sulfa or pentamidine if they can't tolerate that, and IVIG if they have hypogammaglobulinemia. Ready for my case?
Yeah.
All right. So this lady, I have been seeing her for a number of years. She was 56 at the time. She lives 3 hours from our center. Not a very big past medical history, hyperlipidemia and migraine. She's married, has 3 grown daughters. Her brother is actually one of our lead pet radiologists at Mayo Clinic. She herself is a preschool teacher. She works 4 12-hour days a week. You can see by the pictures that her favorite things, she and her husband love to camp in Minnesota. And there's a picture of her preschool, and then they also love to go on these Amtrak train rides. So every year they've got something planned. And in fact, I saw her last week. I said, okay, where's your next trip out to? They're still really enjoying doing that. So she was diagnosed back in 2013. And at the time, I didn't put this on the slide, but she was IGHV unmutated, and she had a 13p deletion. I don't think, she did not have a 17p deletion. Okay, so she was observed, was asymptomatic, and then gradually, in about 2020, just in time for COVID, her white count rose to over 185,000. Her lymphocytes were predominant. She had a decent ANC, but her hemoglobin had dropped to 10, platelets dropped to 104. She was becoming more and more fatigued, which was probably her main symptom. She didn't have any B symptoms. She had progressive lymphadenopathy and splenomegaly, and she had these exaggerated insect bite-like reactions. So if you've seen a lot of people with CLL, you know that this is a thing that happens with them, which was not very great because she loves to go camping, right? Anyway, so at that time, the cool treatment was to put her on this clinical trial with obinutuzumab and ibrutinib. This was comparing ibrutinib and obinutuzumab with or without venetoclax. And so she went on this study. One of her main things that she had was diarrhea, and it was very timely. She knew she took a dose, and 15 to 20 minutes later, she would have a diarrhea stool, would have about 5 or 6 a day. So this is somebody we switched her to taking it at night. She took loperamide as needed, and she actually eventually got resolved. It went away after a few weeks. She had some mild arthralgias and some fatigue, but mind you, the fatigue was actually better because her disease was being treated. So here's her response. Clinically, she had a prompt response. No more palpable lymphadenopathy or splenomegaly after a week, and that was amazing. You can see over on the right, it was her baseline scan. This is kind of just how we do it at Mayo. I don't know, I suppose it looks a little backwards to you. But you can see some lymphadenopathy, but then at her follow-up scan, that lymphadenopathy had resolved. You can see her spleen was enlarged. Notice her ribs are not visible here, so that spleen extended below her rib cage, whereas on her second scan, it had shrunk up a bit, which is great. In about 6 months, she had normalization of her CBC and diff, and she now remains on ibrutinib. She's been on it for almost 6 years now, and she has normal CBC and diff. I always tell her, if anybody looked at your blood count, they'd never know you had CLL. She has no lymphadenopathy, splenomegaly. She's living a normal life, and as I said, they're planning another Amtrak trip. So
that's great. Thank you. So let's just talk for 1 minute about unique toxicities of the different BTKs. In my experience, and I learned the hard way, if someone has a migraine history, ACAL is not going to go well.
Correct. Yeah.
Anybody had similar experience?
Yeah. We often have changed folks from being on acalabrutinib to zanubrutinib would be the next
for the headaches.
Choice, right, for headaches.
Yeah.
And we try to, if somebody's got a known migraine history, we move them over. Yeah.
In general, both ACAL and zanubrutinib are very well-tolerated medicines, significantly better than ibrutinib. I don't think any of us prescribe ibrutinib anymore with Xanu and ACAL available. Xanu, I probably have run into some stubborn hypertension with that drug. So if that is a comorbidity that the patient's struggling with, I might lean more toward ACAL than Xanu. I don't know if anybody can think of any other scenarios where some comorbidity will shift you in one direction or another.
Certainly you couldn't be on Coumadin if you were going to go on any of them.
Right.
So that would be, but you could be on
a DOAC.
A DOAC without a problem. Those are the big ones.
Yeah, I think those are the big ones. Maybe arthralgia sometimes with one versus the other.
Mm-hmm. The last one I'll mention, I don't know if you guys have seen this, we've had a handful of patients who come in with crazy limb edema. One arm, big giant purple arm, or one leg, big giant purple leg. I don't fully understand it, and I've seen it with Xanu, ACAL, Perto. It's been a hard thing to manage because it's quite problematic. Anybody else had just like isolated limb edema? Or are we just lucky?
Not that bad, but once in a while.
Yeah, we've had a few, especially in older folks who are, they may have had some edema coming into it, and then you add on a BTK inhibitor, and that makes it worse. They have excessive bruising in their upper arms, and that may make them more friable, sometimes wrapping them. I don't see one worse than the other in terms of BTK inhibitors with it, but certainly see it.
Well, one thing that might help some of these, and these toxicities that we're focusing on are fairly uncommon, but we're just trying to give you some pearls here. So one of the newer options that's available is to combine a BTK inhibitor with the BCL2 inhibitor, and then you can give it in a time-limited way, which should help mitigate some of these toxicities that we're talking about. So here are my sort of thoughts on first-line treatment. In my mind, there's sort of 4 primary options. You can do continuous therapy with a covalent BTK, either ACAL or Xanu. It's simple. And then you now have 2 time-limited options. You can do Ven/Bin, that's been around for a long time. And now the new player is this venetoclax acalabrutinib, so it's a pill-pill combination that just got FDA approval this year. Now, technically, there are 6 options because per the FDA approvals, you can add obinutuzumab to acalabrutinib, and you can add it to venetoclax acalabrutinib. I find myself rarely doing that. Probably the one scenario would be similar to what Farrukh said when you have a super young, fit, healthy person and you're trying to intensify things. But most of our CLL patients are older, frailer, and I'm not going to use a triplet because of the added risk, and I'll show you that in a minute. I think we've covered these scenarios already. These are factors that might guide your therapy. If they prefer time limited, you now have 2 good options. If they want to avoid infusions, you have 2 options. You can do BTK or Ven/Cal. If they have a significant bleeding risk, maybe they're stuck on anticoagulation because of their atrial fibrillation and they already bleed like crazy, maybe a BTK is not going to be your best friend there. So these are the sort of things that go through my mind when I'm trying to pick frontline therapy for a patient. So we've talked about venetoclax a little bit. It's a BCL2 inhibitor. You don't get the lymphocytosis that you get with the BTK inhibitors, and the remissions tend to be deeper with venetoclax than with the BTK inhibitors. So you're more likely to get a complete response. You're more likely to get to MRD undetectable which really then opens the door for these time-limited approaches. I think Mollie covered the ramp-up and the TLS risk already, so I'll skip through that. And I'm just going to get to the study called Amplify, which was the study that got this ACAL-VEN pill-pill combo approved. So there were 3 arms. ACAL-VEN was one of the arms, and you start out on just the acalabrutinib, and you do that for 2 months, and then you add in the venetoclax. And by adding in the venetoclax after 2 months of ACAL, that mitigates the tumor lysis risk, so you don't have to do, you're very unlikely to need to do hospitalizations or the intensive monitoring because you've already debulked the patient for 2 months. The middle arm added the obinutuzumab, the anti-CD20, and this was compared against chemo approaches, either FCR or BR. So here's what the curves look like, and you can see at 3 years, the 2 novel regimens were better than FCR-BR for probability of remaining in remission, and you can see that the 3-drug combination was a little better than the 2-drug combination. So you might be saying, well, Brad, why don't you use the 3-drug combination? It looks better. Well, look at the overall survival. So the 3-drug regimen was actually a little inferior than the 2-drug regimen for overall survival, and it was because of infections, specifically COVID infections. This trial enrolled during the peak of the COVID pandemic. So if you repeated this trial now, you may not get this same result because COVID doesn't seem to be as lethal now as it was 5 years ago. But I do feel like it's kind of a marker for what it's doing to people's immune system. And so again, if I have a patient who's a little bit on the older, frailer side, I don't want to take on that infection risk. And that's why I'm relatively unlikely to use the 3-drug AVO regimen in most of my patients. So you have all these great options now. If I have an older, frailer patient who just wants to do something simple and safe, single-agent BTK is fine. You can do ACAL, you can do Xanu, they work great. If a patient is P53 aberrant, if they have a mutation or the 17p deleted, single-agent BTK given indefinitely has the best data. I think ACAL versus Xanu, that debate is kind of a toss-up for me. It depends what side of the bed I wake up on that day, whether I'm giving ACAL or Xanu. But I am much more now interested in these time-limited options. I really like the idea of treating the patient for a fixed duration and then giving them a therapy break. So more and more, I find myself steering patients in that direction if they're interested. I'll do Ven-Obin a lot if they're IgHV mutated and the patient's young. But this new pill-pill combo of acalabrutinib and venetoclax is very appealing. And I have a case that I'll kind of go through how well that works. Now, we have another pill-pill combo that's probably just on the horizon here, and this is zanubrutinib combined with sonrotoclax. So sonrotoclax is sort of like a next-generation venetoclax, and you might have seen this week it was approved for relapsed refractory mantle cell lymphoma, and I'm sure it'll get a CLL approval at some point, and it'll probably be a combination approval as well with zanubrutinib. So we're going to have even more options, and here's some of the data for this sonrotoclax-zanubrutinib combination, where you can see very high overall response rates and very high complete response rates with that combination. There are a couple of studies that could influence our practice. I know these are hard to read, but this was a study called MAGIC that is fully enrolled now. This one I'm really interested to see the results because it was ACAL-VEN versus Ven-Obin, but then you did an MRD assessment after a year, and if your patient still had detectable disease by an MRD test, you could continue therapy a second year. And you heard Farrukh mentioned this a minute ago, wondering if the 1 year is the optimal duration of the pill-pill combos. And I wonder that too. I think some patients need longer, and perhaps MRD assessments will help us figure out who should do a second year. And then this was another trial that's also fully enrolled, waiting for results, again using Ven-Obin as the control arm, and compared it against this novel combination of the sonrotoclax, the new BCL2 inhibitor, with zanubrutinib. So here's an example of where the pill-pill combo is really attractive. I met this this woman last summer. She had had her disease for about a year. She started on watch and wait, but the disease was really accelerating when I met her in July. Worsening adenopathy and fatigue. The white count was up to 240,000. She was becoming anemic. But she lived like 4 hours from clinic. It was quite a hike, but she really wanted time-limited therapy. So doing ven-obin would have been a real burden on her to come in for these obinutuzumab infusions. So we had the ACAL-ven data, even though it wasn't FDA approved, it was in the guidelines. So we started her on ACAL-ven. Her white count shot up on the ACAL like it often does, but we started the ven with cycle 3. There was no tumor lysis syndrome, and we just saw her a month ago. Here's her white blood cell count now, 5,600. Her hemoglobin's 12. Her platelets are 120,000. Adenopathy, splenomegaly resolved, and she'll finish her treatment this fall. I mean, it really went smooth. I think it was a great choice for someone like that. So, Farrukh, what proportion of your patients do you think, if the next 100 patients, how many are you going to be recommending time-limited therapy to?
I think all of them. Everybody would want something that they would stop after X amount of months. So that I think in the future it'll be harder and harder to justify continuous therapy.
And then between venetoclax obinutuzumab, which we've had for 6 years now, or the pill-pill combinations, how are you adjudicating that decision?
I don't feel that the pill-pill combos would be in any way inferior than the CLL14 ven-obin data, which the 10-year update is going to be presented soon. So I don't anticipate that result would be inferior. So in my mind, ven-obin is not easy. With the infusion, with the tumor lysis, and the cytopenias. Actually, people don't talk about the low blood counts in CLL. Cycle 1 cytopenias is hard. So you have to manage the patients, get them through it. So ven-obin is not necessarily the easiest option, but it is a very effective option. In my unmutated and TP53, that would be not my preferred option. In those patients, I would probably do zanubrutinib sonrotoclax or acalabrutinib venetoclax, and then for all others, I would leaning more and more towards the pill-pill option.
The obinutuzumab reactions can be, frankly, terrifying at times. My treatment room NP, Nicole, is in the room, and every time I send a patient over to start obinutuzumab with CLL, I'm just thinking, Nicole's going to hate me today because it can really be dramatic. And so I do think these pill-pill combinations are a really nice option to be able to offer our patients. Yeah. So let's move on to Module 6. We're going to talk about non-covalent BTK inhibitors, and Farrukh's going to start us off.
Yeah, and one of the ways to mitigate obinutuzumab infusion reactions, and if you start obinutuzumab cold turkey, especially with a high count CLL patients, you will be called, you will be paged. So if you want to avoid a page, if you don't want the nurse to freak out who's giving the obinutuzumab, a month, a week, 3 days of a BTK inhibitor before the obinutuzumab makes a huge difference. We had a clinical trial in which we treated 50 patients who started off with BTK inhibitor and then started the obinutuzumab, and I forgot how to manage an infusion reaction. And I thought maybe they changed the formulation somehow, but no, it's basically a well-known fact that adding the BTK inhibitor, even for 3 days, if you do that before you start the obinutuzumab, it makes a huge difference. But obviously, if you're using ven-obin, you don't have that luxury. So moving on to acalabrutinib, ibrutinib, and zanubrutinib are all first-generation BTK inhibitor. This is the BTK. We all have it. In our cases, it's on and off. When we need it, it turns on. In patients with CLL, it's perpetually on. That's why the cancer happens. What does ibrutinib do? Ibrutinib turns it off permanently. Zanubrutinib turns it off. Acalabrutinib turns it off. After some time, the cancer gets smart and does this. And now, ibrutinib cannot bind. This is called BTK resistance mutation. Hopefully this is pretty clear. Now, what do? We come up with pirtobrutinib, which does this. That's how we keep moving along. So pirtobrutinib binds at another site. It's on and off binding, and that's what's called a non-covalent BTK inhibitor. Nemtabrutinib is the same. Now, and the next step after this is the cancer cell does this. And that's called resistance to covalent and BTK and non-covalent BTK inhibitors, or sometimes gatekeeper mutations or kinase dead mutations. You don't even see the arm. So what do? We flip the whole arm off. I'm serious. This is what's called a BTK degrader. Bexubrutideg is coming out, and that's exactly how it works. So as the cancer gets smarter, we get smarter too. Anyway, moving on to pirtobrutinib. This slide used to be pretty simple, 2 colors. It was red and blue. Half the people would pick blue, half the people would pick red. And now it has green, and it has multiple other colors. And you can see we are sequencing these, and it depends on what you had in the front line, how long the remission is, and then you decide what you use in the second line or the third line. But look at the x-axis here, 14 years, 15 years, 20 years. We are essentially making it irrelevant, essentially, and you can live your normal life, and that's the goal. Yeah, so I have to take a pill. My argument is, the question that was asked was, will I offer time-limited treatment to all my patients? Yes. But they take unlimited treatment for hypertension. They don't complain. More people die of strokes than CLL. So what's the difference? It's the C word, as I said earlier. It's the cancer word. That's a stigma attached to it. Yeah, you can argue that it's so expensive, the cancer medicines, but ibrutinib is going to be generic pretty soon, so then it will be cheaper. It's already cheaper right now. Not as cheap as amlodipine or lisinopril, but sure, it'll be generic soon, and then it'll be cheap. So then who cares? As long as your blood pressure is controlled, you take a pill. Diabetes, I can go on and on. But this is how it used to be. Some people would be on it, some people would be time limited, on and off, and so on. And now we have made it more complicated. We have the shades of blue, we have the greens, and then we have the blacks. The point is, it's great for our patients, and we can sequence these things around, and our patients do really well. So one of the things that happened was pirtobrutinib. Pirtobrutinib was the first non-covalent BTK inhibitor, and when you see a waterfall like this, that's great. I mean, every single patient responded. Now, some of them responded very nicely, and that's what the waterfall plot shows you. But pretty much, except for that one little patient on the front end, every single patient responded to pirtobrutinib. So this is why pirtobrutinib was very effective. And that's why it was fast-tracked and it's approved. It's a very, very effective drug in patients who failed BTK inhibitors and BCL2 inhibitors. And the best thing about pirtobrutinib was that it was very well tolerated. So if you're evaluating the toxicity of a drug in a clinical trial, what I look at is the grade 3-4 column. Grade 1, grade 2, everything causes grade 1, grade 2. I don't like the taste of water. That's a grade 1 toxicity. So let's be real. Now, if water caused me anaphylaxis, that's a grade 3-4 toxicity. Now we're talking. So grade 3-4 toxicities is what I tend to focus on if you want to be quick about it. And if you look across the board, except for neutropenia, which is a common problem in patients with CLL, low blood counts, pretty much every other count is like 5-ish%. Very well tolerated drug. I would still be careful with the bleeding risk because that's a class effect of these drugs. I would still not take it lightly. Other than the bleeding risk, the 3 days for a minor procedure, 7 days before a major procedure, warfarin, we talked about, don't do it with warfarin. Azoles, big one, fluconazole, increases the concentration of the drug significantly. So those are minor things that you want to think about with pirtobrutinib. Otherwise, it's a very well-tolerated drug. It was eventually compared to ibrutinib, which was the first one. That's how you really want to see how effective your therapy is in patients who were BTK naive, including treatment-naive patients. Now, this study showed clearly that pirtobrutinib was much more effective, both in terms of response rates, tolerability in the treatment-naive patients, in relapse patients, and patients did really, really well. And pretty early on, within 2 years, the curve starts separating, and that means that one drug is better than the other. Pirtobrutinib curve looks much, much better within 2 years, which is nothing for CLL because patients do well for a long time. And then in terms of treatment-naive population, the curve is even more prominent, and there's a significant improvement in outcome with pirtobrutinib. My only problem with this is there's nothing wrong with the efficacy, but what happens is that if I'm shutting this off and the cancer does this, my first 3 drugs become ineffective. And that's a speculation. I don't have anything to prove it, but that's a fear that I have, that if you continue therapy continuously, you breed resistance. This is why I'm not for continuous therapy. Clearly, pirtobrutinib was much better and less toxic than ibrutinib. No debate there. And I think other than the bleeding issue, you should be fine with pirtobrutinib. Atrial fibrillation is not an issue. And then, obviously, we're combining pirto with different agents to improve the efficacy further. So with that, I guess I'll have a case. Okay, so let's look at this case. 72-year-old female diagnosed with CLL at the age of 65, pretty usual. Unmutated IGHV, del13Q, high risk, but not the worst. del11Q, why is del11Q important? del11Q patients have lumpy disease, big, bulky lymph nodes. Wild-type TP53, so don't have the TP53 mutation, initially watched, started on ibrutinib monotherapy, 5 years, and then had progression. This is different from intolerance. People who are intolerant and stop treatment for intolerance will do really, really well. But people who stop therapy for true progression have much more aggressive disease. She also has type 2 diabetes, hypertension, renal failure, but not on dialysis. My classic patient. You know, it's never a patient that's going to be on a trial. They have 17 other problems. All right. Imaging now shows bulky lymphadenopathy and splenomegaly, and she has a cysteine 481 mutation. We have a fancy name, PLC gamma 2 mutation, L528 mutation, and so on. But she has del11Q still, and she has a new mutation. So obviously, zanubrutinib isn't going to work, acala isn't going to work. Patient desires oral therapy, minimal back and forth to the cancer center. Will you give venetoclax or obinutuzumab? Will you give pirtobrutinib? I think the answer in this kind of situation would be pretty simple, that pirtobrutinib would be the safest option, even though we don't have a lot of data on renal failure patients. If the patient needs therapy, that's what I tend to do for these kind of patients and continue therapy perpetually. So you have to look at the whole scenario and then decide how you want to proceed.
Mollie, take us through tolerability of this new class.
Bring it home.
Yeah.
Bring it home. We keep talking about this side effect profile, and hypertension, AFib, neutropenia, almost across all of these oral Bruton's tyrosine kinase inhibitors. When someone reports bleeding, you monitor if they're on any other forms of anticoagulation. Tends to be a bit more when they're on something like aspirin as opposed to a DOAC. Instruct the patient about procedures. We keep driving this home about procedures. Hold it for procedures, hold it for procedures. And we say 3 days, it's 3 days before, day of, 3 days after. And they should notify you of any time they're having a procedure done. Notify the provider if there's any blood in your urine or blood in your stool or bleeding gums that don't stop. Bruising, kind of common, not too worried about that. Atrial fibrillation, monitor, teach patients how to look for the signs and the symptoms of having atrial fibrillation. Do you feel like your chest is fluttering? Oh yeah, I've been having that for weeks. Okay. Do you feel like you're getting short of breath or more fatigued? If they already have hypertension or a history of arrhythmias, they may be at increase for having these things happen. Infections can happen, especially when you use combination therapy, or in the beginning as therapies are getting started out. You may have come in with a not so great neutropenia or a neutrophil count and may require growth factor support. We tell patients to call anytime they have a temperature above 100.5. Don't take Tylenol and see if it comes down. That's not helpful. It's helpful for you to feel better, but we want to know if you're going to have a real fever. Evaluate them promptly, whether it's through the ER or an advanced care setting. Consider prophylaxis in patients who are at high risk. If you've had shingles and you haven't had a shingles vaccine, antiviral vaccine, antiviral prophylaxis, bacterial prophylaxis, particularly we said PJP, but that's in patients who have been kind of heavily pre-treated. We don't normally start people on antibiotics. Patients will often call and say, I'm having dental work, are you going to put me on an antibiotic? We don't. We follow the American cardiology guidelines. If you have a valve or a replaced limb, then a replaced joint, or a replaced limb, but mostly a joint, right? Then you get an antibiotic.
Yes.
I'm just asking you as person to person here, Awan.
Yes. Joint prophylaxis.
Joint prophylaxis.
Joint replacement.
Joint replacement. Thank you. Monitor CBCs regularly. There's dose modifications for Pertobrutinib in the package insert. You hold for first occurrence and then wait till it goes back to grade 1. Certainly in neutropenia, you may want to hold it. You may have to go down on the dose. You may certainly give growth factor. We tend to be a group who try to stay at the full dose and use growth factor support as much as we can. We want to push through so these folks get as much therapy as they can. We talked about this being a therapy for Pertobrutinib is given in patients who may have failed a BTK inhibitor, and that's the most common reason that people come off a BTK inhibitor. One of the frontline BTK inhibitors is from a resistance mutation that develops, and Pertobrutinib doesn't care about the resistance mutation. It latches in the same area, but kind of obliterates the whole attaching area. So it's good in forms of that. We haven't moved it into the front line, except there's a good role for it in some older folks who are a bit around. They're not bitter. They could be bitter, but they're mostly a bit on the frail side. And so we've moved it into the front line there. But Pertobrutinib is usually it's not a long haul drug. You're going to likely need something after Pertobrutinib. And so we talk about this as being a bridge to CAR T therapy.
Let's skip the case and move to the discussion question. So we have these this new non-covalent BTK inhibitor. Do you folks think this is a better BTK than the other ones? Is it better, more well tolerated? Is it similar? What's your experience been? Start with Mollie.
I think they're pretty well tolerated on the same level. I don't see that one is easier than any of the others. I think they are all generally easy to take. Then again, I'm not taking them. But I think they're very well tolerated across the board, the BTK inhibitors.
What do you think, Robin?
I agree. I've been able to see some people on clinical trials, and Pertobrutinib has been amazing. They don't even feel like they're taking anything.
Any parting words of wisdom, Farrukh?
I think they ask us this question about what's the rationale behind 3 days of holding the Pertobrutinib or Recalibrutinib, and I tell them to again think about why we started holding it for 3 days. It's because at 3 days, 50% of your platelets are recovered, and these drugs inhibit platelet function. So that's the rationale behind 3 days. Stopping the drug, platelets are 50% recovered. By 7 days, you have 100% platelet turnover. If you do have a patients who do present with massive bleeding, like we used to see when we weren't sure of what was happening, the only thing that works is a platelet transfusion, even if their platelet count is normal, because it's a platelet functional defect.
I want to thank our great panel of speakers for all the education they provided tonight. Thank you, audience. Hopefully you're having a great ONS meeting. Thank you.